Welcome to our virtual event on inequity in cancer care. I'm Tina Reed, Axios healthcare editor, and I'm coming to you today from Washington, D.C. Welcome to our audiences on Facebook, YouTube, Twitter, LinkedIn, and on Axios.com. Join the conversation today on Twitter with @Axios and #AxiosEvents. Over the next 30 minutes, we'll examine ways to reduce inequities across all aspects of cancer care, from screenings and research to treatment and access to life-saving drugs. Our first guest is the Deputy Assistant to the President for the Cancer Moonshot and Deputy Director for Health Outcomes at the White House Office of Science and Technology Policy, Dr. Danielle Carnival. Thank you for being here today.
Thanks, Tina. Good to be here.
So President Biden first launched his moonshot in 2016, and that had a goal of advancing progress on cancer research, on finding a cancer cure in 5 years, a decade worth of research in 5 years, and ultimately end cancer as we know it. He relaunched this program last year with a slightly updated goal of ending cancer as we know it. I was hoping you could talk about what that goal is and how we should be thinking about the approach to tackling cancer through that lens.
Yeah, thanks so much for the question. Like you said, the original goal was to really speed up everything we could that impacted a patient back in 2016 at the end of the Obama-Biden administration. But last February, the president and first lady stepped up this effort and said, we want to reignite the cancer moonshot and mobilize a national effort to end cancer as we know it. This means achieving two clear goals: to decrease the death rate from cancer by at least 50% over the next 25 years. That means preventing more than 4 million cancer deaths by 2047. And the second goal, to improve the experience of people who are touched by cancer.
Can you talk about some of the math involved when you talk about reducing the cancer death rate by at least 50%? How much is just the clear inequities we have in the cancer survival rate in the U.S. Play into actually reaching that goal?
Yeah, so listen, we have seen a huge amount of progress in saving and extending lives from people facing cancer, or even preventing cancer diagnoses in the first place. Over the first 2 decades of the century, the cancer death rate has been reduced by 25%, and we've seen an acceleration of that improvement since 2016, driven by prevention, early detection, advancements in treatment for some cancers. But as you point out, that has not reached all Americans equitably. We see disparities in the impact, the incidence, and the negative outcomes from cancer, especially in Black communities across this country. And so the reason we set a quantifiable goal is because we know we're gonna do what we measure, and we cannot reach that 50% goal without bringing everyone and all cancers, progress against all cancers, along with us. So it's a huge focus. We need to make sure that we have new tools to prevent, detect, and treat cancer. But a huge part of this effort is making sure that the tools we have today and those we develop along the way reach all Americans.
So, for instance, when you talk about trying to change cancer as we know it, we're not only trying to change the treatments, but improve the screening. Is that what you're talking about?
Absolutely. For one example, the president and first lady, right out of the gate with the reignited cancer moonshot, shined a huge light on the fact that during the COVID pandemic, Americans had missed nearly 10 million cancer screenings. That number has grown since then. But we know that it wasn't equitable access to cancer screenings and use of cancer screenings in the first place. And so they put a call to action for across the federal government, and we've seen new programs that are reaching Americans in all 50 states and many territories. And they put a call to action to the private sector. Last May, we saw the initial response to that, and we've seen continued new programs, new collaborations, new actions from organizations and academic institutions and nonprofits all across the country to make sure that the tools we have today to detect cancer early, when we know we have so many more tools to treat and have people walk through survivorship, and make sure that we're reaching more zip codes, more communities across this country with screening and early detection.
So part of this is also the actual cancer treatments themselves. Projections are that the Inflation Reduction Act will save Americans who get a brand name cancer drug through Medicare Part D an average of more than $7,000 per year. And yet drug companies are saying that it could stymie innovation in life-saving drugs. At the same time, we also have some really real market challenges with getting common, cheap cancer drugs to patients. So how do you ensure your goals of impacting cancer survival aren't threatened by some of these really real pricing issues?
Yeah, I mean, I think it's part of the solution is addressing the fact that Americans who are facing a cancer diagnosis can actually pay for the therapies that will work for them. That is part of how we achieve the goal of ending cancer as we know it. And so the part of the Inflation Reduction Act that caps those out-of-pocket costs for individuals on Medicare is a huge benefit to those facing cancer. And like you said, will save them thousands, if not tens of thousands of dollars a year, depending on what therapy they're on. The other thing you pointed at is the issue or the challenges in the generic drug market and making sure that chemotherapy drugs right now that have been noted to be in shortage are reaching more people. This is a problem not just in cancer, and it's one that this administration is taking very seriously, has from the beginning of the administration when we were in the middle of the pandemic and addressing some of these shortages. And we're really doubling down and making sure that the therapies we have today can reach folks who need them.
Well, what about the warnings from drug companies about innovation being slowed by some of these efforts to lower drug prices?
Listen, so the goal of the Inflation Reduction Act in the drug pricing side, like I said, is to make sure that people aren't having to lose their life savings or mortgage their house to receive life-saving cancer treatment and others. I think the balance that was reached to kind of negotiate on a set of drugs and move forward from there, and the balance to make sure that we are robustly investing in innovation from federal research and development dollars is one that makes sense and one that assures that that Americans can get access to these therapies.
I wanted to move on to talking a little bit about efforts that are being made specifically to get at the heart of why we see such disparities and how to actually address them. The NIH recently awarded $50 million to create new centers to research how to improve cancer outcomes in low-income areas. What are the metrics for success there?
Yeah, I mean, that program is part of a much bigger effort. From the beginning of the administration, the president has focused on making sure that Americans have access to quality healthcare and healthcare coverage. That we know that makes a difference in cancer outcomes and many other disease outcomes. The work that NCI is leading is to really understand. I feel like for so long we've talked about buzzwords like social determinants of health. And what that really means is that there are so many things stacked up against people in some communities. They don't live close to specialized care. They work jobs that it's more difficult to take time off to get access to cancer screenings. Transportation to a facility to get treatment is a challenge and costs money. And so the work that NCI is doing, but really we're doing more broadly as part of the Cancer Moonshot, is understanding what we do know about what interventions make sense and what support and aid changes those outcomes. One big thing the president talked about as part of the State of the Union this year is navigation. And that means someone who is sitting down with someone getting a cancer diagnosis and talking them through their options, talking to their family about the support services that might be available. We know that makes a huge difference in individual outcomes, and it makes a difference in how people feel the experience of going through a cancer diagnosis and treatment is. And we're taking steps that the president called on us to take to make sure that that is a service that is reimbursed and covered for as many Americans facing cancer as possible. We think that's one part of the solution here.
So we're coming up on time, but I did want to ask you if there's just one big thing you hope listeners take away today in terms of the biggest impact, or the thing that could make the biggest impact on cancer survival rates in the US, what would the one thing be?
Yeah, that's a tough question because there's so much I want to say in response. I think we are really focused on preventing cancers that can be prevented. That means decreased tobacco use. That means HPV vaccinations. And I'm going to choose that because what's better than having a treatable cancer is not having cancer in the first place. And I think there's tools we have in our hands today around nutrition and smoking cessation, which we've put a huge focus on and want to help every individual American across the country who wants to quit smoking or doesn't want to start in the first place and needs support. And we have a growing set of tools that really will change our relationship and end cancer as we know it, as the president puts it. The other thing I have to add is that from the beginning, this was about listening to people most directly impacted by cancer and building priorities based on what they say they need most. And that's because it was personal for the president and the first lady to start this. But the reason it's a presidential priority and a priority of this administration is because it's personal for nearly every American. And so we want to bring folks together, and everyone can do their part, whether it's that personal responsibility around prevention and screening, companies and organizations stepping up and being part of the solution, or our whole of government approach to finding every way that the federal government can make sure we're delivering against this goal to save lives.
Well, Dr. Carnival, thank you so much for your time today.
Thank you so much.
And next, we have a View from the Top segment with Mia Vallow.
Thanks, Tina. And thank you to our sponsor, AstraZeneca, for making this conversation possible. Now joining us is the Senior Vice President and Head of U.S. Oncology for AstraZeneca, Mohit Munro. Hi, Mohit. Welcome to Axios.
Thank you, Mia.
Let's go ahead and dive in. Mohit, can you tell us what you've observed in the cancer care landscape today?
Yeah, Mia. Before I get in there, my role here as head of U.S. Oncology is really focused on bringing science to practice and ensuring that every patient is able to access. Me and my teams here, they work day in, day out to make that happen. And in that context, when we look back, there's a lot that has progressed in cancer care over the last 3 decades. Now, roughly 33% reduction in mortality in cancer has been observed over the last 3 decades, which is great progress. But having said that, there's a long way still to go for many people living with cancer. Something that I observe every day in, day out, and through my different roles in different parts of the world, is that an individual's health outcomes end up being defined by the zip code they live in or by the demographics. And this is something which is true, even though we've made so much progress on the back of driving screening as well as precision medicine-based drug development, that there are historically marginalized communities that continue to lag. And there is disparities in care that exist across the continuum of care. And this is something that needs to be addressed.
How should we approach eliminating the gaps in cancer care for the patient populations that you've just highlighted?
It's important to first and foremost look at those cancer care gaps and actually agree that no one individual organization or group can solve for those. We need to work together and collaborate and look at those holistically to solve for and make meaningful progress. In that spirit, at AstraZeneca, we have laid out our Accelerate Change Together, what we call as Act on Health Equity, where we are really focused on ensuring that we can move the needle for these patients across clinical trials, as well as the delivery of science in the medical practice. And to do that, we got to ensure that we have got a holistic input from different stakeholders, and we've created what we call an advisory health equity advisory council that is formed from distinguished individuals from different walks of life and expertise that help us guide our activities. Now, we can get all that insight and drive actions, which will be important and meaningful, but they will not go all the way if we do not work on the ground with different communities and different organizations, and that's where we partner a lot. For example, we partner with ACCC on their rural Appalachian lung cancer screening initiatives that is helping bring human-centered lung cancer screening to those groups that have been historically not being able to access that. Similarly, we partner with When We Trial Group because, as we all know, Black women end up with worse mortality rates in breast cancer, and that's because historically they have not been included in clinical trials. So working with When We Trial, we are creating right opportunities for them to get onto the trial. So again, looking at the challenges holistically, getting input from broader groups and working cross-functionally is how we can, and cross-functioning and cross-industry stakeholders is how we can solve for those care gaps.
Can you talk to us about how you believe public policy can play a role in your work to achieve equity in cancer care?
Yeah, public policy is absolutely essential and critical as it relates to removing barriers, putting laws and legal approaches in way, but also importantly in setting up incentives for things to progress. And I'll quote a few examples here. If you go back a few years, there were very little treatments available for orphan or rare diseases. The Orphan Drug Act actually spun a lot of innovation, with today now 650 plus approvals and 50% of them in cancer space, on the back of the ODA incentives and the policy being shaped around those. That was great. At the same time, we know that for example, we are working closely with both federal and state governments in ensuring that we are supporting the bills which are on lung cancer screening or broader cancer screening, multi-cancer screening, as well as on diagnostics, so that every patient or every individual has an opportunity to access those in the right space. Similarly, IRA, Inflation Reduction Act, I think there are some great elements in the act, like ensuring the capping on out-of-pocket for elderly, but at the same time also smoothing of the payout they have to in their support is something which is great and we are supportive of. And these are the ways policy can actually remove barriers and creates incentives in the system to drive that. While I say that, it is also important to know that if the policy is not thought through or not put in the appropriate place in the right time, it can actually create disincentives or could have unintended consequences. And again, within IRA, there are multiple of these which could actually put us back from where we are today or the progress we have made. Again, 9 years versus 13 years on oral drugs in terms of price setting timeline is an unintended consequence. Similarly, orphan drug exclusion you get excluded from price, or you get included into price negotiation as soon as you have another orphan disease designation, will get in the way of discovery of science and medicines, because it's a linear process. You learn over time and you develop in different spaces. So again, it's important to work alongside our policymakers to put policies in place, but also be open and willing to step up and raise voices when the policies could get in the way of innovation and science.
As you've outlined, cancer care is changing in a big way, both in terms of the science and public policy. When you think about the future of eliminating inequity in cancer care, what keeps you up at night?
Yeah, it's the same thing that kept me up at night in my different roles in different parts of the world, that science is moving at such fast pace. It's so promising. But that science is not meeting every patient in every corner of the world at the same pace that it is being developed in labs and in clinical trials. And that's, again, where my team and me play a role. But that's where that defines us in terms of moving the needle for them. It should not be the zip code lottery that defines your outcome. It should not be your ethnicity. It should not be your background. It should not be what you earn and what you can afford. We need to really ensure we understand the barriers. We really put in place right incentives to solving for those. We look at historically marginalized communities and work with them to bring them in the system and ensure they are able to access that innovation. And most importantly, we work together as one ecosystem, because there's no one individual organization or system that can solve for these. So those are things that keep me up at night, but also keep me motivated to driving more.
Thank you again, Mohit, for joining us today and sharing the important work that you and your team at AstraZeneca are doing for cancer care.
Thank you, Mia, for having me.
And now back to Tina Reed.
Our final guest today is the Director and Lippman Chair in Oncology at VCU's Massey Cancer Center, Dr. Robert Wynn. Hi, Dr. Wynn. Thank you for being here today.
Oh, thank you for having me.
I wanted to get started by talking a little bit about yourself and your approach, because it's pretty interesting. You do what are called district walks. Could you describe what that is, and how did you first get started in doing these walks around the community?
Yeah, it was apparent to me that as a cancer center director, we have been very good at creating the next molecules that would become medicine. We were very bad, however, at understanding of where the medicines wound up and how they impacted our communities. I thought that the best way to get that information would be for me to initially just take a couple community walks. I thought it was actually going to be one walk or two walks, and I was going to be into that. But it started up being really a regular process and a valuable one for me, because when you're walking with your state reps or your state senators or your mayors or your district folk, you get information that is not readily available by public databases. And that is, you get real information from not only them, but from the community members that come out. So for me, it really is changing the model from academics having the bench to coming to a bedside and then doing good to communities. It's really switching that and reversing that to a people to pipette sort of model, in which we're out in the communities, and that is informing and helping to inform the type of research and refining our research questions that we believe will be a better help to serving communities.
In particular, one of the places you've been walking was Petersburg. Where is Petersburg? Can you describe what you found there and what you were able to do with that information?
You know, within the Commonwealth, I have to say that independent of what happens in Northern Virginia, when you look at Central, Eastern, and Southern Virginia, we have a lot of poverty and a lot of cancer burden disease. Petersburg is an example in which you have a city that's not that far from Richmond. And yet, when you go to that city, the level of poverty, the level of increased rates of cancer. In fact, Petersburg not only has some of the highest rates of obesity within the Commonwealth, but it has the lowest life expectancy even for white men. So when we think about places around the Commonwealth like Petersburg, it's important to not just read about it or have data from publicly available sources, but when you go there, you recognize that those folks there absolutely want the best care, but they just don't have the access to it. And so that gave us even more of an impetus to start figuring out how to develop programs in which we could reach out and give access to care in places like Petersburg and Dansville and your Lynchburgs and Martinvilles around the entire Commonwealth.
In particular, there was a clue that you learned there, though. What were you hearing from women when you were walking around the community and chatting with people?
It's the best story ever. This is how people say, well, you know, scientists, you know, come up with great ideas and then they just do it. Well, this one happened literally because I was on one of those, what we call walkabouts, and there were a group of women who were talking to me about those women cancers. They were like, well, what are you doing about the women's cancer? And I said, what do you mean, breast? And they were like, no, not breast. And I was like, ovarian? They were like, no, not ovarian. I went, well, endometrial? And they were like, that's the one. And it turns out I had never thought about endometrial cancer as being a major significant issue, particularly within the African-American community. It turns out that when I went back and asked Leslie Randall, my then Gynonc chair, what was going on, we had recently recruited her from California. She said, "Oh my God, I've never seen such aggressive types of cancer. And in fact, we don't even have medicines for it." That gave me the idea of bringing a group together. This is real people to pipette. So we brought a group of our basic scientists. We brought Leslie Randall, who's a gyne-onc clinical trialist, and other people together. And believe it or not, out of that came the first clinical trial that we hope will be a difference maker, particularly for African-American women that are not responsive to the standard therapies currently. And this is an example of the triumph of what happens when you listen to your community. But in addition to listening, when you become a part of it, when they're not just engaging the community, but you're integrating within the community to get this type of information, it's just very cool.
And you touched on this a little bit, but I mean, why are we seeing these disparities? You've mentioned both racial disparities. I think you've talked before about the rural versus urban differences that we see in survival rates and in cancer rates. What do you think are some of the key drivers here that are leading to these differences in cancer rates and in their outcomes?
I would say that the one thing we have not paid attention to are the structures. George Weiner from University of Iowa, who was a cancer center director there, and I actually wound up writing a paper together in which we were able to clearly understand that the rural disparities of increased unnecessary deaths from cancer, particularly lung cancer and colorectal cancer and breast cancer, mirrors that of some urban underserved groups. And in fact, what we figured out is that there is more similarities between your rural and, say, your urban underserved groups in the context of the poorer outcomes. It's important to know that the contributing factors are not so much social determinants, I stopped calling them determinants, but more social drivers of health. That is simply access to care. Do you have not only the access to care, but the quality of care once you get it, the access to clinical trials and all the rest of that is actually disproportionately unbalanced. Telehealth, for example, is a wonderful tool, but when you think of who benefited most from the telehealth, it's people that lived 2 miles within academic centers that benefited and that used telehealth mostly. So I think we have a long way to go of understanding how the role of structures are contributing to unhealthy communities. And in addition to creating new molecules, what we hope here is that we're now paying attention to addressing these structural issues as well, both for our rural and our urban underserved communities to make everybody healthy.
So a great place to look at an example of how do you address these structures. Let's talk about clinical trials. I mean, how do you change the structure of how you conduct clinical trials to get better diversity and not only to in the recruitment, but in the retention of those who are participating?
So one thing I figured is that doing the same thing does not get you different results. So what I did was I've gotten together with groups like Bristol Myers Squibb, Genentech, and others, and Gilead, Amgen, AACR, and others to sort of retrain how we do business. We now have groups for the first time ever in history, of clinical trialists that are not only learning how to design and how to implement the high impact trials, but are learning what to do with a community asset map before they design their trials, that are learning how to work within communities. You're not going to get more diverse patients onto clinical trials without different training and understanding that there is a science of outreach and engagement that needs to run parallel to the science of design and implementing trials. And we think that we will have great success in the future and a big impact in getting more diverse patients on the trials. By the way, I'll end with sort of saying real quick that in the 21st century, that when you reach the end of the road of the standard of care in cancer, the standard of care is access to clinical trials in the 21st century.
Can you dig in just a little bit more, though? What does it look like to change how you do things?
Yeah, for once, this has been really cool. We have never had groups of people who would design clinical trials be posed with the following questions. Great. So you have this wonderful medicine, you have this wonderful trial. How are you going to get people from Martinsville into your trials? These are questions that they've never were posed by. We now have about a number of trainees a year that are now actually being not only given those questions, but actually giving the charge to solve those issues. And so we're teaching them how to use things like community asset mapping. We're teaching them to actually understand what a community map is and what an infrastructure looks like that can be leveraged, right, with community champions to be able to actually get trusted sources so that people not only trust you, but that people in those communities also have access to our best and brightest as well. So we're starting to do things a little bit differently by things like the Win Diversity Award and other Diversity Scholars Award and other things like that, which are talking about different approaches to getting people on the clinical trials, as well as the next molecule that becomes medicine, and that both equally need to be part of a clinician's training to be impactful, we believe anyways.
We're getting close on time, but I did want to ask about the recent news that your cancer center became an NCI designated comprehensive cancer center. What impact does that make on the access that patients in your area have?
I think becoming a comprehensive cancer center is a big deal for us. It means that we will be able to save more lives. We have more access to more research, access to more medicines that we think will serve the Commonwealth in a big fashion. I also think it's an argument for why we should relook at the NIH program, the National Cancer Institute program, and thinking about how we can get more cancer centers out into places like West Virginia and your Arkansas and your Mississippi's. It turns out that where there is a cancer center, a comprehensive cancer center, in this case, Commonwealth benefits significantly, not just because I said it, but because the data that actually vets that out with other cancer centers that have become comprehensive. So we're excited about the comprehensive status and excited about saving more lives and doing more good.
Well, Dr. Nguyen, thank you so much for your time today.
Thank you.
Thank you all for joining us this afternoon for another virtual conversation that has made everyone smarter, faster. For more on the latest developments in cancer care, or to sign up for my Vitals newsletter, visit axios.com/newsletters or go to the Axios app. Thank you all for joining, and we'll see you on axios.com.